Hello, I'm Dr. Thomas Patterson from San Antonio Center for Medical Mycology and the University of Texas Health Science Center at San Antonio, Texas. Welcome to this unique educational activity focusing on the diagnosis and treatment of invasive fungal infections. Invasive fungal infections have emerged as important infections in the last 3 decades as causes of human disease. Although superficial mycoses will be much more common in overall global prevalence of infection, the IFIs are associated with disproportionately high morbidity, mortality, and economic burden. These patients frequently require admission to hospital and more intensive antifungal therapy. Many factors have contributed to this rise in the emergence of IFIs, including uncontrolled HIV disease, a dramatic rise in the number of patients receiving a growing array of immunosuppressive therapies, and increasing populations with frequent nosocomial exposures or interventions. Let's look at fungal diseases that do impose important threats to public health for several reasons, and to separate out the types of infections that we see. The first group of infections I'll discuss are opportunistic infections. Those would include agents like Aspergillus, Candida, even Cryptococcus, and become increasingly problematic as the number of people with weakened immune system rises. Hospital-associated infections such as candidemia are really the leading causes of bloodstream infections from a fungal point of view in the United States. And then the last group would be infections that could be acquired in the community. These are typically endemic fungi, that is, organisms that live in the environment in one stage, like a mold, and then in the host transform thermally to a yeast-like phase. These organisms are inherently pathogenic and cause disease even in normal hosts. These would include coccidioidomycosis or valley fever, histoplasmosis, blastomycosis, sporotrichosis, and others. So these usually occur from the environment and occur in specific geographic areas. These fungi are sensitive to changes in temperature and moisture, so it may well be these changes in climate over the long term may affect their geographic distribution and growth. It's also important to look at the yearly incidences of invasive fungal infections. Candida is the most common opportunistic of the fungal infections, with an estimated 400,000 cases worldwide per year. Mortality will range from really low numbers in less immunosuppressed patients to higher rates of mortality in those with more immunosuppression. For Aspergillus, it's still relatively uncommon with 200,000 cases, and again, mortality that ranges pretty dramatically. The literature will show mortality rates that are extremely high in those with late diagnoses to low amounts in those with relatively low amounts of immunosuppression. Pneumocystis still remains common in uncontrolled HIV, and mucormycosis is increasingly seen in many settings with an estimated 11,000 cases a year. Better therapies have improved that mortality, but the diagnosis is still difficult. If we look at the endemic and dimorphic fungi, those rates of infection are relatively low overall for invasive disease, with coccidioidomycosis being likely the most important in terms of the number of cases and estimated mortality. As we've traditionally assumed, coccidioidomycosis is prevalent in the Southwest. It does extend into Texas. In Texas, none of these are reportable diseases, so we don't have a very good handle on the rate or extent of disease in our state, but that's true in many areas. You'll notice on the map that there are increasing pockets that appear to be endemic areas for coccidioidomycosis, and that likely relates to a number of factors, including climate change and weather. Blastomycosis is more prevalent in the eastern United States, but we and others have seen cases outside the endemic zone, which are likely associated with other organisms that are either blastomycosis or highly related that are outside that typical endemic zone. So it's important to keep that in mind in diagnosing these infections. Histoplasmosis is most common in the southeast United States and in the Ohio River valleys, but it'll also include the St. Lawrence River Valley in the north, so it's really pretty extensive geographic range. If we look at the clinical manifestation of these infections, it's important that a spectrum of disease occurs and correlates pretty closely in these patients with the extent of immunosuppression. With aspergillosis, in hospital, we focus mostly on acute invasive pulmonary aspergillosis due to the immunosuppression these patients have. We worry about those infections developing in disseminated infections, which is much more difficult to treat and associated with higher mortality. But recognize the spectrum can also include allergic-related infections like pulmonary conditions like chronic invasive sinusitis, allergic bronchopulmonary aspergillosis, and even the development of chronic pulmonary aspergillus syndromes. With candidiasis, the most common presentation that we see is that of superficial infections. That is thrush, infection in the mouth, but also vaginal candidiasis, which are, as you know, extremely common worldwide. Those, while being very problematic in the patients who develop them, aren't usually associated with more extensive disease or morbidity, mortality that is very high. On the other hand, it can become very chronic and difficult to treat conditions, especially recurrent vaginal candidiasis, so that the management of those patients with that recurrent infection can be very difficult and can be associated with resistance. With invasive candidiasis, we worry about usually line-related candidemia. We want to make the diagnosis early before we get more invasive disease and end organ damage, like the eye, invasive disease in a bone, cardiovascular endocarditis disease, or even neurologic syndromes. With mucormycosis, the spectrum is also varied. With mucormycosis, the disease usually requires some sort of immunosuppression. You can certainly develop cutaneous necrotizing mucormycosis. That would frequently be associated with line or bandages, but we worry more especially about rhinocerebral mucormycosis and pulmonary disease. With rhinocerebral mucormycosis, that would typically be in the setting of steroid use, but even more typically diabetic ketoacidosis, but can also be seen with hematologic malignancy, post-chemotherapy, and other conditions, and certainly pulmonary mucormycosis can be seen in those patients as well. It's important to assess the risk for invasive fungal disease with at-risk populations. For aspergillosis, we think of transplant patients, particularly patients with hematologic malignancies, and those with extensive steroid use. For chronic lung diseases, aspergillus can occur in patients with prior tuberculosis, COPD, sarcoid, and other underlying lung diseases. With Candida, we especially worry about patients with central venous catheters or other invasive catheters, especially after recent major surgery. That would most particularly be abdominal surgery or any sort of condition, even trauma, a gunshot wound, that allows the gut lumen to be transversed. So in that setting, we worry about exposure of patients to Candida from the gut. But that could also include chemotherapy that causes extensive mucositis, which would also include the bowel tract, allowing the organisms to become in the bloodstream from that leaky gut syndrome. You couple those factors with broad spectrum antibiotics and other underlying risk factors like necrotizing pancreatitis, critical care patients, hemodialysis, corticosteroid use, and other immunosuppressive agents, that will dramatically increase the risk of invasive Candida infections. With Mucor, as we've mentioned, those infections are typically diabetic patients with ketoacidosis, but we can also see it with trauma and burns in immunocompromised patients. You can also see it with patients receiving agents for iron overload like deferoxamine. We don't typically as commonly see that as we did previously, but can it also occur in patients with advanced AIDS, with IV drugs from persons who use drugs intravenously, malnutrition, iron overload states, and even in neonates and premature infants. Because of the difficulty in diagnosing these infections, there have been a number of attempts to make clinical prediction scores. Those have been done to assist us clinically. While the scores themselves may not be things that you really want to implement in your practices, I think taking some of these concepts, you can use that in a clinical practice to make a diagnosis. One example of this would be the invasive pulmonary aspergillosis score that Blott and colleagues developed from ICU patients. And in that setting, they looked at over 100 ICU patients with a positive aspergillus endotracheal aspirate. So does that equal infection or not? That's an important question. They basically then looked at other positive parameters that would correlate with that, like obviously compatible clinical signs and symptoms, abnormal chest x-rays or CT scans, and abnormal host factors like immunosuppression. All those would increase the likelihood of that positive endotracheal aspirate equating with infection, right? So in that setting, the outcomes looked at it and basically showed that in fact the sensitivity and specificity of those characteristics really even outperform the EORTC MSG criteria, which isn't really very surprising since those criteria were developed for a different patient population, those patients with underlying cancer or malignancies. So it's an example of ways that you could use predictive scores to help you in your assessment of these patients. With Canada, a number of groups have looked at prediction scores over the recent years. Playford and colleagues from Australia looked at a large number of non-neutropenic ICU patients to try to predict who might end up with disease and factored in a number of features that we've just talked about would be associated with higher likelihoods of developing infection. Those would include things like emergency GI or surgical procedure, right, in the hepatobiliary system, but also central venous catheter use as an important risk factor, admitted to ICU from operating room, emergency department, or even outside hospital. Parenteral nutrition we know increases risk, and then broad spectrum antibiotics and prior positive cultures. When those scores were tabulated, you found reasonable sensitivity and specificity, but clinically, I think you could use those as well. Another predictive algorithm looked at a large number, again, of non-neutropenic patients, included pancreatitis, central catheters, drains, signs of sepsis like tachycardia, but also samples positive for fungal colonization. And again, the sensitivity will vary pretty dramatically, but reasonable specificity overall. Luis Strosky-Zeichner has done a lot of work in this area through the mycosis study group and others, and have really associated more likelihood of infection with Candida in non-neutropenic patients due to mechanical ventilation, antibiotic use, central catheters, and at least one other risk factor. Sensitivity was, again, pretty limited, but with specificity that was overall reasonable. Leon and colleagues developed easy-to-use criteria that looked at surgery on admission, TPN, sepsis, and multifocal Candida species colonization. So clinically, I think we use those sort of criteria to establish a likelihood of disease and possible use of early empirical therapy. The reason we use early empirical therapy was shown by Morell and colleagues now a number of years ago, but basically they showed that hospital mortality was dramatically increased with delayed antifungal therapy for candidemia. In their series of over 150 patients with candidemia, if an antifungal therapy was initiated within the first 12 hours after a blood culture was drawn for suspected Candida, mortality was dramatically decreased compared to those with later initiation of therapy. And you can see that in their series, most patients back then had delayed antifungal therapy for 24 to 48 hours. That would be typically when cultures would begin to turn positive, and so therapy would be initiated. But you can also see by delaying therapy that long, you had an increased overall mortality. And the mortality increased in patients who were sicker, which is understandable with prior antibiotics, but most of all with the administration of the antifungal therapy was really important early on. For antifungal treatment strategies, there's a number of different approaches ranging from antifungal prophylaxis, risk factors, prediction scores, and colonization. Empirical therapy is the situation where we use signs and symptoms of infection, but yet to be confirmed. Preemptive therapy uses some sort of marker, a beta glucan, galactomannan, PCR, some other sort of preemptive marker that could guide therapy. For targeted therapy, that's when we're able to de-escalate if we don't have the presence of the organism or establish another source of the fever or infection. And that obviously has a high specificity, but would be later in the course of infection. If we look at recommendations from the IDSA guidelines in the version that was published in 2016, it was recognized that most laboratories in the US locally did not have the ability to do molecular tests like PCRs for Aspergillus and other molds. So it wasn't available in real time in many of those settings, and that it was assessed by our panel that in fact that the ability to culture, identify the organisms, to test for resistance would be an important maneuver. If we look at the laboratory diagnosis of aspergillosis for non-culture based samples, we do have a number of tools now at our disposal, including galactomannan, which is increasingly readily available. The sensitivity from serum is not as high as that from other sources like BAL, and it'll certainly be limited in the setting of prior antifungal exposure, especially in asymptomatic persons where the sensitivity drops dramatically. The beta glucan is nonspecific for fungus, but it would include Candida and Aspergillus, not other molds like Mucor and not Cryptococcus, but can be an important adjunct and is increasingly available. PCR has now been added to the most recent definitions from the EORTC MSG group. And because of that, I think that needs to be increasingly recognized as an adjunctive measure in many settings. There are some lateral flow devices that are increasingly being offered clinically, and that is a more rapid test that can be done locally in many settings. If we look at the role of imaging and bronchoscopy in the diagnosis of invasive pulmonary aspergillosis in the IDSA guidelines, it's recommended with a strong recommendation and high quality evidence that a CT scan is really recommended whenever there's a clinical suspicion for invasive pulmonary aspergillosis, really regardless of the chest radiograph results. It's really recognized that the chest radiograph is not very sensitive and with extensive disease possible by CT. A bronchoscopy is recommended in most of those patients as well, with suspicion of invasive pulmonary aspergillosis. With Candida, it's really important to culture blood and other samples under sterile conditions. That's really our diagnostic standard. Non-culture diagnostic tests such as antigen, antibody, beta glucan, and PCR are entering clinical practice as adjuncts, but really are not readily used and available in clinical practice. Cultures are really important in that setting, and increasingly we're able to get a more rapid result from a positive blood culture with systems like the BCID and other molecular tests for Candida and Candida albicans and other species, including Candida auris in some settings. And then the identification of the organism to the species level by MALDI is important. And as we previously mentioned, T2MR and other molecular tests are increasingly available in some centers to allow an early diagnosis of invasive Candida infection. If we look at the availability of different laboratory tests, these mainly include the beta-D-glucan and the 2T-MR. Other systems such as the PCR testing or germ tube formation or Mannan or anti-Mannan antibodies have not really been very effective in a clinical setting for the diagnosis of invasive Candida infections. The diagnostic pathway for mucormycosis has been recently published by the ECMM Global Guideline Writing Group for diagnosing suspected mucormycosis in many settings and how it's approached. And these include neutropenic patients, diabetic patients, trauma, and other conditions, but even in specific regional settings as well. In most of these guidelines, CT assessment of the affected areas is really a recommended procedure. In that evaluation, sampling by biopsy is really critical, with the recognition that grinding these samples for mucormycosis would allow these pauciseptate organisms to become unviable. So it's important for the lab to recognize what you're looking for, to look microscopically to see if you see the non-septate or pauciseptate ribbon-like hyphae, to culture at 30 and 37 degrees, preferably with a chunk of tissue that then could allow identification and susceptibility. We do molecular testing either on tissues or other samples. And serology is also important, not so much at the present time for mucor, but for the presence of aspergillus and other fungi. So the obtaining galactomannan and the beta-glucan would then suggest support of that differential diagnosis, although mixed infections can clearly occur. There have been a number of clinical trials evaluating diagnostic methods for invasive fungal disease, or IFIs, and those would include tests that look at pan-fungal PCRs, the evaluation of BALs from samples with hematologic malignancies. Novel biomarkers have been evaluated for Candida, and then lateral flow devices to assess the ability to detect disease in BAL fluid and others. Let's turn now to look at practical overview of available antifungal agents. So there's a number of different antifungal drugs that are now available. As you know, amphotericin B has been around now for 60 years, but it's still a useful compound. Amphotericin B deoxycholate is rarely recommended in most settings for life-threatening disease, where we now use liposomal forms of amphotericin in most invasive fungal disease applications. For azoles, we still have a lot of utility for fluconazole, even though resistance has increased. With itraconazole is an important agent for less life-threatening infections, particularly endemic fungi, but new forms of itraconazole have now been introduced, suba-itraconazole, which allows better bioavailability. Voriconazole is an agent that we have had a lot of experience with, especially for aspergillus and other molds. With posaconazole, now with extended tab formulations, we're able to give that agent orally in many more patients with good bioavailability. And then isavuconazole has been associated with good outcomes in aspergillosis and in mucormycosis, with less toxicity compared for aspergillus to voriconazole, or with mucormycosis compared to lipid forms of amphotericin or amphotericin B deoxycholate. The echinocandins have been very effective for candidemia and invasive candidiasis as their major target, but as we'll talk about in some degree in combinations for infection with aspergillosis. Flucytosine is an important adjunctive therapy in cryptococcosis. Its major disadvantage currently is its extensive high price in the developed areas of the world due to limited supplies, and to its lack of availability in areas like sub-Saharan Africa, where it could be very effective for use in cryptococcus but is not widely available. There are a number of different sites of actions for the approved and emerging antifungal agents, but mainly include the ergosterol plasma in the plasma membrane. The cell wall as a unique fungal target is increasingly recognized as an important one that can hopefully limit clinical toxicities. Flucytosine targets DNA RNA synthesis, and then other agents have been developed as well. If we look at empirical treatment for suspected invasive candidiasis in non-neutropenic patients, the IDSA guidelines recommend that empirical therapy be considered in critically ill patients with risk factors for invasive candidiasis, especially if there's no other known cause of fever. A workup should clearly be done, but as we've shown earlier, should be started as soon as possible, especially in those patients with likely septic shock and in those who have extensive risk factors for Candida disease. Echinocandins would be recommended in most of those patients. Fluconazole could be considered, especially if recent azoles have not been used and they're not colonized, patients aren't colonized with azole-resistant Candida species. You could consider lipid formulations in that setting, but because of an ICU setting where you have a lot of renal insufficiency, those are less commonly used. If we look at treatment of candidemia and invasive candidiasis by the IDSA guidelines, it follows on that same recommendations, with echinocandins as recommended initial therapy for most patients. You could use it as an alternative to fluconazole in less critically ill patients, but that's increasingly less commonly done in a clinical setting. We talked about lipid formulations are possible, especially if resistance has occurred. In some organisms, like Candida auris, that might well be a maneuver you might have to undertake, or even more commonly for resistant Candida glabrata, lipid formulations of amphotericin may need to be used. Step-down therapy is really important. Fluconazole is the drug we would like to use in those settings, but we would need to confirm susceptibility. That can be done clinically within as few as 5 days or so to allow oral therapy to be given. For Candida glabrata, you need to transition to higher doses of fluconazole. Cross-resistance with VORI is really common, so we do that really with a lot of trepidation. But you also need to remove the catheter as soon as possible if you can. You also need to make sure blood cultures become negative, and we nearly always treat for 14 days after the first negative culture. Is that necessary in all patients? Probably not, but shorter courses have not been studied, and it's easy enough to do in most patients with oral therapy. We do a dilated fungoscopic exam within a week of the diagnosis, which is recommended in all patients. That's come under question recently on how cost-effective that is, but the problem is it's very, very difficult to predict who will develop end organ or eye disease, and so it's an easy to perform maneuver that most of us continue to do in our clinical practice. In neutropenic patients, the guidelines are similar. In that setting, we worry more about prior azole exposure. So in that setting, echinocandins are generally the recommended agent. And we avoid fluconazole even in settings where the prior azole exposure has been the extended spectrum agents. We do, in some settings where mold coverage could be used, VORI can be an alternative agent, but you need to make sure that patients don't have Candida glabrata or are likely to have Candida glabrata in that setting. Step-down therapy, again, could be with flu or with VORI, especially if you are considering mold-active prophylaxis. Again, especially in candidemia that's line-related, you need to remove the line. But it's recognized that in many patients with neutropenia, that's a more complicated process. And in those patients, the gut is an important source, especially associated with mucositis. So in that setting, it may not be necessary as consistently in all patients, but it certainly should be considered on a case-by-case basis. For invasive aspergillosis, the IDSA guidelines strongly recommend voriconazole in most patients, but recognize that liposomal amphotericin B and isavuconazole were important alternatives for toxicity, for drug tolerance, and even potential resistance, especially for liposomal amphotericin. Salvage agents clearly need to take into account prior therapies. We didn't recommend combination therapy routinely in most patients, but consider it in those high-risk patients or those with more extensive disease. In those patients with salvage, you really need to consider a switch to other agents, but it needs to be an individualized process. If we look at the head-to-head comparison of isavuconazole to voriconazole in invasive mold disease, the overall outcomes were similar, but drug-related adverse events were significantly different and favored isavuconazole in that setting. It also was not a major part of the paper, but that initial report actually also showed that isavuconazole blood levels were very consistent and usually good as compared to voriconazole, where the bioavailability is certainly variable. If we look at additional recommendations for treatment of aspergillosis, empiric and preemptive antifungal can be recommended with really any of the agents. We worry about using the echinocandins as single agents, even for empiric and preemptive therapy in that setting. But preemptive therapy is a logical extension of empirical antifungal therapy in high-risk patients. We don't do empiric therapy just for fever as commonly anymore without any evidence for possible pulmonary disease, but that needs to take into account local procedures and availability of diagnostics. Prophylaxis against aspergillus is indicated by the FDA with posaconazole based on the trials, but the other agents can also be used clinically in an off-label setting, especially as secondary prophylaxis in those high-risk patients. Breakthrough recommendations for the management of aspergillosis and other molds is really tricky. You need to aggressively establish a diagnosis if you hadn't had one before, but even if you had one before, to really make sure that's still the diagnosis. In other words, do you have a breakthrough infection of another resistant organism or another organism of some sort, or could you have even a mixed infection? You need to verify the serum azole levels if TDM is available, and then especially think about changing a class. The data don't really support that 100% conclusively, but that's what most people would do just because you worry about the potential of a resistant organism being present, or even less commonly, the development of resistance. So for instance, if voriconazole was the agent you were on, you would probably consider a change to lipid formulation of amphotericin for increased spectrum of coverage. Proposed approaches for combination therapy in the management of invasive aspergillosis and transplant has more recently been proposed. Obviously, with aspergillosis, we really like to reduce immunosuppression if we can. That's important to improve outcomes. With milder disease, I think single agents are what we would typically do. With refractory disease, either think about changing to liposomal amphotericin or use combinations really earlier than later. With more severe disease, you could use voriconazole and echinocandin as prior therapy and then stop the echinocandins after you've documented good voriconazole or other azole levels. But you may consider either switching to or adding liposomal therapy with more recalcitrant drug-resistant or CNS disease. And then finally, in hematopoietic stem cell transplants, in that setting, you can use voriconazole and echinocandin, usually more upfront in those higher risk patients, especially if a high serum galactomannan is present or with refractory disease. And that's based on the first-line combination data study that overall, as you know, didn't meet the primary endpoint in the entire cohort, although it favored the combination of voriconazole and anidulafungin. But if you looked at those with galactomannan positive cases, there you did meet the significance at mortality improvement at 6 weeks. If we look at the ECMM guidelines for mucormycosis, again, really important is surgical debridement, if at all possible in those settings. You really want to give full doses of drug really initially. With more recalcitrant or CNS disease, higher doses of liposomal therapy can even potentially be used. Other agents, sabuconazole and posaconazole, are really important additions to our armamentarium. The pre-existing renal compromise would be a setting that you would definitely consider azoles over the liposomal amphotericin in that setting. But in the setting of sabuconazole, you obviously would avoid the cyclodextran and you would allow the drug to be given intravenously. Other agents like the oral suspension of posaconazole, lower doses of liposomal amphotericin, and amphotericin deoxycholate are really not recommended. You obviously need to assess responses very carefully. With progressive disease, you can consider a switch to the azoles if you didn't use it up front, or even combinations in some settings. And with toxicity, obviously change therapy as needed. What do you do if lipid formulations of amphotericin are not available? Well, obviously, you've got to pivot to other choices, but even then, amphotericin deoxycholate is going to be associated with extremely high mortality, so that the availability of sabuconazole and posaconazole, either orally or IV, is really key. If sabuconazole and posaconazole are not available at all to you in those settings, which in most areas that should not be the case, then your options really are for liposomal amphotericin. And again, the guidelines would suggest that amphotericin deoxycholate will just not be very effective in that setting. If we looked at the clinical trial, the VITAL study that looked at outcomes of proven or probable invasive mucormycosis, Overall, the outcomes were seen in patients with primary disease or with refractory disease that overall was around 38%, but you can see that the outcomes would vary depending on whether it was given for primary disease or refractory infection. The proposed approach to combination antifungal therapy in transplant patients was also recently published, and in that setting, again, reduction of immunosuppression was key, reversing metabolic disturbances, and then consulting your surgical colleagues pretty immediately for debridement if at all possible. In that setting, higher doses of liposomal amphotericin are generally recommended, especially for severe disease, and echinocandin is added, especially in non-neutropenic patients. It may be an adjunct to host defenses in patients with white cells that are present. In neutropenic patients, that addition is less likely to be effective, and go with step-down therapy if at all possible. Finally, let's focus now on optimizing therapy and how to approach disease. Obviously, you need to take into account the antifungal drug, the dosing regimens, and the host. So some things we can modify, which drugs we use. The host is difficult to modify, but not impossible. We've talked about improving the outcomes by reducing immunosuppression, but also by patients recovering from their underlying condition, like a hematologic malignancy. If those happen, your outcomes are going to be significantly better. It's obviously difficult to modify the fungus. You've gotten whatever you've gotten, right? But it is important to identify the fungus. We can do that, and then we can do susceptibility and guide therapy more specifically on what fungus we identify. So we look at a number of factors when we choose antifungal therapy for an IFI. We look at spectrum of activity, the toxicity profile, the distribution to the site of infection, and PK/PD parameters. The spectrum is important. The echinocandins will cover the Candida species in most cases. We worry some about resistance to Candida glabrata, which is increasingly seen with Aspergillus. We have good susceptibility to amphotericin with little resistance reported except in some species, so not usually Fumigatus, but in some other species like Aspergillus flavus and the cryptic species, but Aspergillus terreus as well, where the extended spectrum azoles will be better candidates from a susceptibility point of view. With Mucor, we still consider susceptibility to amphotericin, posaconazole, and isavuconazole, but there will be some species differences, so identifying to a species level is important. With other molds like Fusarium or Scedosporium, voriconazole and posaconazole have good activity. Activity with isavuconazole is going to be variable. And then with the endemic fungi, amphotericin has good activity against most. Voriconazole and fluconazole are less useful in many of those infections. One exception would be coccidioides, where fluconazole is an important agent and the drug of choice still for central nervous system disease, although we worry about the development of fluconazole resistance, and voriconazole would be similar. But for most endemic fungi, for the azoles, itraconazole, posaconazole, and isavuconazole would all three be more effective against most of those agents than fluconazole or voriconazole. Antifungal susceptibility is increasingly recognized as important. It allows us to get a relative estimate of the activities of different agents so we can choose more appropriately. In some classes, like the echinocandins, very little differential susceptibility occurs. With the azoles, we definitely see differential susceptibility, so that's an important maneuver to make. There are approved diagnostics by CLSI and the UCAS system using broth microdilution systems in most settings. Other methods can also be used. Their automated methods are available for Candida. Auger screening is available for Aspergillus resistance. It's easy to perform and easy to interpret. That's done with itraconazole, but it's only a screening test that then needs to be backed up with broth microdilution. But e-test or gradient diffusions can also be used against these organisms as well. In a clinical setting, routinely you need to identify Candida isolates to a species level for sure. Similarly for Aspergillus, if you can. For the identification, if possible, of non-Candida albicans yeast isolates from deep sites is also important. as is Candida albicans. In non-sterile sites, that can also be an important clue to invasive disease, so it's something you need to keep in mind whether that's worthwhile to do susceptibility or not. But identification to the species level is something that needs to be considered, especially for sterile site aspirates. Susceptibility testing of flu and vori, as well as the echinocandins, are increasingly available for Candida species, and so it's something that you really need to consider. In many settings, especially for Candida glabrata, you can assume voriconazole resistance with fluconazole resistance because cross-resistance is so common. Certainly with clinical failure of initial therapy, your interest in susceptibility testing across the board is really increased. So in that setting, you would really think about susceptibility testing really for most agents if you can do it, although breakpoints are not well established. Now, in fungi, susceptibility testing is not really as necessary because intrinsic resistance is more common, like Aspergillus terreus and Amphotericin. With Candida krusei, you have resistance to fluconazole and flucytosine and good susceptibility to voriconazole. With Cryptococcus and Trichosporin, you have intrinsic resistance to the echinocandins. With Mucorales, you're going to have resistance to voriconazole, certainly fluconazole, and the echinocandins. But in those settings, because of differential susceptibility to other agents, you would like susceptibilities if you can. We don't see acquired resistance very often, fortunately. With glabrata, you can get acquired resistance really to all the azoles, even amphotericin and the echinocandins. With Candida auris, you can get acquired resistance really to all the antifungals, and similarly for other Candida species, resistance can develop as well. With molds, we definitely want to identify it to a species level if we can. A routine susceptibility is not recommended in most settings, but I do think increasingly we do that for differential susceptibility of different agents, especially to determine the potential cross-resistance, although again, clinical interpretive breakpoints or criteria are less well established. The CLSI and UCAS standards for broth microdilution now take into account species' different susceptibility patterns. That means that for Candida albicans, the breakpoints are going to be different than it would be, say, for glabrata, and that's based largely on the presence of wild-type isolates. So we know that, for example, with Candida glabrata, if you have an MIC that's increased, that even though you may not always see clinical failure, the presence of a non-wild type isolates, that is with mutations in the target gene, is highly likely to be present, and your increased risk of failure is dramatically improved. And similarly, the breakpoints for the azoles also take into account different Candida species overall to allow a differential susceptibility to be recognized. Amphotericin susceptibilities are not particularly useful for yeast. With UCAS, the breakpoints have been proposed, but again, it's not extremely useful. Let's turn now to talk briefly about adverse events. Certainly, we worry about hepatic toxicity, especially from the azoles, but you can also see it from liposomal amphotericin, less commonly from the echinocandins. Renal toxicities are mostly going to be related to amphotericin and polyenes. We do see the buildup of cyclodextrans with renal insufficiency, although that association with renal failure is really less common. CNS side effects can occur, especially with voriconazole, including hallucinations, but also our other CNS events. But also eye effects. The photopsia is really isolated just to voriconazole, although it hadn't been associated with long-term toxicities. We do worry about cutaneous events. That's been reported with voriconazole, especially from photosensitivity with development of malignancy and long-term use. We can see cardiac toxicities with the QTC shortening actually seen with isavuconazole, but prolongation with all the other azoles, especially with drug interactions. GI toxicities are going to be more common with 5-FC, with posaconazole, itraconazole, and bone marrow suppression with 5-FC, and occasionally with amphotericin, but not very commonly. Do we care about antifungal pharmacology? We certainly do, because PK, PD is really important with these agents, and it's important to understand how PK, PD can impact the overall outcome of your patients. The dosing regimens take into account a number of features, concentration versus time in serum. So we look at different outcomes in those patients and then correlate antimicrobial effect versus time, or pharmacologic or toxic effect overall. If we look at an overview just briefly of amphotericin formulations, we know that the amphotericin half-life from deoxycholate is really long. Similarly, you see that with liposomal formulations with long half-life overall. You have higher serum levels with liposomal amphotericin compared to the other lipid drugs. The other agents, fluconazole, voriconazole, and isavuconazole, all produce different pharmacokinetics. Fluconazole has a linear pharmacokinetics, is really well absorbed. It's one of its major advantages, and has fewer drug interactions compared to the other agents, but important to keep in mind in some settings. With voriconazole, you really need to track levels because of the varied PK that you'll see. With isavuconazole, you see much more consistent bioavailability, although you do end up having interactions with cytochrome P450 3A4 overall. With itraconazole, as we've talked about, you end up with a lot of cytochrome interactions, particularly 3A4, with variable absorption, really not allowing it to be used in higher risk patients, as that's also true for the posaconazole oral suspension, which really isn't recommended now. With posaconazole tablet formulation, we can often get really high levels, and so that's important because of the potential adverse events you can see in that setting, so that you may need to measure levels in the highest risk patients, not only for low levels, but higher levels overall. And then similarly, posaconazole IV also contains a cyclodextran, so would have those similar sort of contraindications to voriconazole. The PK of the echinocandins is very similar. There are some differences, but clinically, those really are not very commonly important in the clinical arena. So let's finish now with a discussion of a few cases. Just briefly, this first case shows a patient who was a 58-year-old man undergoing a sigmoid colon resection for diverticulitis and abscess. He was given vancomycin, piperacillin, tazobactam, bicentral catheter. Post-op, he's unstable, gets broad-spectrum antibiotics, his renal function's worsening, his creatinine is elevated. He certainly has a number of risk factors for invasive candidiasis, and certainly has criteria that would suggest potential sepsis in that setting. So the question is there a need for antifungal prophylaxis at this point, and would you do that or not? I think it's a clinical decision at this point. I think many of us would actually initiate echinocandin therapy, especially while we're doing an evaluation. I think if you do the evaluation, this turns out to be Pseudomonas sepsis, there's no evidence for Candida, you are able to stop the antifungal drugs, not continue them in that setting. On the flip side, if you don't discover an etiology, then you may well need to consider a course of antifungal therapy empirically in that setting. So 7 days after therapy, this same patient now develops a fever that's very high, 103.5. Blood pressure is low with an elevated white count. More broad spectrum antibiotics have been given. Given this patient's current status and risk factors, what would you do now, and why would you do that? Well, I think a couple of things you would really do. One is you want to evaluate the abdomen to make sure, do you have an abscess that's developed you've not treated? Do you need to drain that abscess for better source control? That's really clearly been shown to be a major factor in improved outcome in these patients. What else could you or should you do? You certainly do blood cultures. You reevaluate the lines to make sure you don't have a line infection, right? But you also consider, if you haven't given antifungal therapy, I think now you'd certainly want to give antifungal therapy. Could you give an azole? You perhaps could, but I think most of us, and the guidelines would suggest in a critically ill patient, that echinocandin therapy at this point in an empiric basis would be an indicated maneuver. So let's take a patient, a 26-year-old female with an allogeneic stem cell transplant, and consider the question of breakthrough fungal infection. So this patient's been receiving antifungal prophylaxis with fluconazole, 400 milligrams a day since the day of transplant. You surely could argue in that setting that a broader spectrum than fluconazole could be used. but this patient was on fluconazole, which some centers still do, especially if they have low rates of Aspergillus disease and the ready advent of early diagnosis. So 16 days after the transplant, she's still neutropenic. She's febrile without clinical or radiographic evidence of invasive fungal disease. That's a really important feature because you want to make sure you've evaluated that patient with a CT. You want to have evaluated with galactomannan, with beta-glucan, and do a good clinical exam because you want to make sure, are you going down the track of a yeast infection like Candida? Are you going down the track of mold like Aspergillus or other invasive mold disease? So the next day, blood cultures come back for yeast forms. So let's evaluate a couple of things. One is, in a transplant patient, you especially want to make sure that the yeast form is Candida and not Cryptococcus. With a stem cell transplant, Candida is going to be way more common than Cryptococcus. In other transplants, like a liver transplant, you've really got to consider the potential of Cryptococcus. So you make sure your lab gives you an early diagnosis because you don't want to give an echinocandin. In that setting, you would need to give a lipid amphotericin formulation pending evaluation. So back to our patient. Which antifungal therapy would you initiate at this point, and why would you choose that? Well, again, it's really important to think about what you're treating because you don't want to just choose an antifungal off the shelf because you are able to do that, because now we have differential susceptibility. So all considered, we have a blood culture positive for yeast forms. We don't suspect it likely to be Cryptococcus, and we don't have any evidence that the patient has pulmonary disease. So we're really thinking about a Candida species. Which species we really think about? You really got to worry in this setting about Candida glabrata because of the fluconazole this patient was on. Could it be other fluconazole resistant species? Certainly it could, like Candida krusei, and we learned that from our colleagues many, many years ago. But in that setting, echinocandins would be an agent that you would choose, and then you would tailor your therapy as appropriate with more identification of the organism. So what about a 72-year-old woman hospitalized due to fever, cough, and respiratory distress 10 weeks after she received an allogeneic stem cell transplant at an academic hospital, but 3 hours away from her home? She comes to her community hospital near her home. There are no infectious disease specialists on staff there. The hospital has to have a contract-based remote infectious disease consultation. But 24 hours after initiating antibiotic therapy, imaging, which is really important to do, you really would make sure you get good imaging. Certainly you should be able to do that at most facilities. But now it indicates nodular infiltrates in both lower lobes without cavitation. So what's the best course of action for this patient? We're not really told what antifungal prophylaxis was given. One might guess that it was an azole of an extended spectrum like posaconazole. If that were the case, I think the best course of action is certainly going to be to try to do a BAL, if at all possible, and culture the organism so you know exactly what you're dealing with and could do susceptibility. But even more so, if you were on prior antifungal prophylaxis with an azole, in that setting, the use of an azole is really going to be more limited until you have proof of what you're dealing with, so that liposomal amphotericin would be your likely drug of choice. If, on the other hand, for whatever reason, she wasn't on extended spectrum azole prophylaxis or even on just fluconazole prophylaxis, in that setting, the institution of a extended spectrum azole like voriconazole, isavuconazole, or even posaconazole could be used. In this patient, you might also consider, because of her risk factors, the addition of echinocandin, at least even initially or very early on in the course of disease, pending evaluation, which would include serum galactomannans and BAL galactomannan as well. And then we have a 37-year-old obese man presenting 2 days ago to the emergency department with severe sinusitis, fever, and necrotizing skin lesions. He's had uncontrolled diabetes and active ketoacidosis, recent history of glucocorticoid use to treat asthma. Now, 2 days after admission, the patient's in critical care unit, deteriorating rapidly as the skin necroses rapidly worsen. So he deteriorates despite 7 days of broad-spectrum therapy, first at home pre-admission and then hospital with his antibiotics given IV. So what's the best course of action? Well, clearly this is a case where you really need to establish the diagnosis. So necrotic skin lesions sort of randomly are not very common with mucormycosis. Those skin lesions are going to be more associated with IV lines or even dressings or bandages, but it can occur. A biopsy would really be important in that setting. You want to make sure you're not dealing with some other kind of infection that does make necrotic skin lesions, even bacterial disease, but from a fungal perspective, agents like Fusarium can do that, so you'd really want to know what organisms you're dealing with. But in this setting of ketoacidosis, we really worry about mucorales. And in that setting, the best course of action is certainly going to be to treat the diabetic ketoacidosis, to have your surgical colleagues debride what they can. You basically want to evaluate for extent of infection, including the sinuses, rhinocerebral disease. You also want to make sure you've biopsied any of the lesions you could, and then you give early antifungal therapy. And in this setting, liposomal amphotericin, I think, would certainly be the drug that in most settings you would choose as an early empirical therapy while your diagnosis was being conducted. Could you choose an extended spectrum azole that covers mucorales like isavuconazole or posaconazole? You could. But in most cases, especially pending the diagnosis and evaluation, I think liposomal amphotericin would be most of our choices in that setting. Would we give combination therapy? Probably not initially, but the use of the echinocandin to expose the galactomannan on the surfaces of these organisms could be done to allow for the white cells to contribute to the response, but it wouldn't be a maneuver that would usually be done as an initial line of treatment. So to summarize, hopefully we've discussed in a practical and clinical way the importance of diagnosing fungal infections. It's important, first off, to recognize the potential for fungal disease. So classical diagnostics can be used like cultures and radiographs, but increasingly molecular tests are available for us, as are non-culture based diagnostics. So those can all be important adjuncts to our management of these infections. We do have now an extended spectrum of agents available to us for use. So it's really important to recognize what agents we're likely to be treating if we're doing it empirically or preemptively, and then to adjust those agents, particularly when we've been able to establish a diagnosis and even considered the potential for resistance. And then finally, how do we select antifungal agents for clinical use? Again, we take into account a number of different features that suggest the likely risk factors for certain infections, whether patients have seen antifungal therapies before, what the underlying host risk factors are, whether patients are likely to have bloodstream disease or pulmonary infection, and all those combined with the spectrum and PK/PD of our agents are able to guide our therapy for clinical use. So I hope these discussions have been helpful for you in your practice, and good luck, and thanks for joining us.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.